Now, considering the diabetic food is a major morbidity throughout the world, I would like to share some information in this regard with you. What is the interventional radiology role in diabetic food management? Well, first of all, there are some specificities in diabetic food involvement, arterial involvement in diabetic foods, which makes it kind of different from other atherosclerotic disease in terms of management. First of all, the main location of problem is subpopliteal, and the involvement is kind of multi-segmental, which makes it an association with renal and cardiac problems, which makes it a little different in terms of management. And there are, in addition to medical management, there are some intravascular procedures, angioplasty, stenting, kind of things that which is done both by interventional radiology procedures and surgical procedures, including angioplasty, stenting, locoregional fibrinolysis, mechanical arterectomy, which this in this I mean this improvement in managing of diabetic food, allowing us to select more patients to make them a good candidate for treatment and get a better result out of that. Well, there is a group who are working on diabetic food, IWGDF, which creates guidelines for managing of diabetic food in domains of diagnosis, prognosis, and treatment. And based on that, for diagnosing a diabetic food problem, you should examine the patient with diabetes at least annually, and it's good to do ankle or pedal Doppler arterial waveforms. And there are some criteria which exclude peripheral arterial disease in overally, and including diabetic patients. ABI more than zero point 0.9, toe brachial index more than 0.75, and presence of a triphasic pedal Doppler arterial waveforms. These things meant that there is no peripheral arterial disease in a patient with diabetes, so there is no indication for either endovascular or surgical procedure. Uh, in terms of prognosis, there are a lot of debates, and there is no single thing that predicts that what's gonna be the outcome. And overall, it's recommended that a multidisciplinary approach to diabetic food is taken to just involve different specialties to manage this condition. But I found this in articles that these things increase the pretest probability of healing at least 25%. If there is a skin perfusion pressure equal or more than 40 millimeter mercury, a toe pressure more than equal or more than 30 millimeter mercury, or a TCPO2 equal or more than 25 millimeter mercury. And if these things exist, we know that the outcome probably is gonna be better. And there are some conditions that indicates urgent vascular imaging and revascularization. If a patient with diabetes had ulcer and the toe pressure is less than 30 millimeter mercury, or TCPO2 is less than 25 millimeter mercury, or if there is an ulcer which doesn't improve within 6 weeks despite optimal management. And another one is when there is a non-healing ulcer with either and ankle pressure less than 50 millimeter mercury, or ABI less than zero point 0.5. Uh, in terms of treatment, we have to say that there are, before doing any revascularization procedure, we have to take an anatomical information either by Doppler, CT angiography, MRA, or DSA. And the aim of revascularization in these patients is restore direct flow to at least one of the food arteries, preferably in the arteries that supply the region that the ulcer is placed. And the goals of treatment in these patients is minimum skin perfusion pressure equal or more than 40, and toe pressure equal more than 30, or a TCPO2 equal more than 25 millimeter mercury. And about whether the endovascular intervention is preferred or surgical bypass, there is actually inadequate evidence to support that which one is superior. But all in all, in terms of morbidity and mortality, the evidence favored interventional radiology procedures. And about the procedures we do in diabetic food, I have to say that it is not the only thing that help diabetic patients. In addition to the revascularization procedures, a patient have to have optimal medical management and ulcer observation, etc., to help them have the better results. For the procedure, we prefer antegrade puncture, and what vessel we start with is usually the vessel with best outflow, or where the ulcer situated. And first we try crossing the lesion intraluminally with 0.14 recanalization wire. And if this failed, subintimal route with 0.35 guide wire to re-enter the lumen above the ankle joint is performed. And the best way is using long balloon with inflation device, which diameter should be around 3 millimeter for above ankle, and 2 millimeter for below ankle arterial dilatation. And the end point of our procedure is assessed by assessing of flow. So when good flow, including outflow observed, residual stenosis even more than 30 is considered accepted. At the end, I would like to say that because the diabetic foot is a worldwide problem, and it's the first reason of amputation all around the world, I hope more researches will be performed in terms of choosing the best method of treatment in this group of patients.